Welcome to The Explainer. Today, we're dissecting a landmark study that could change how you manage one of the most common clinical dilemmas. We've all been there, right? You're looking at a carotid ultrasound that shows a severe, yet totally silent stenosis in a patient who feels just fine. It's that classic ticking clock in the neck. And today, we finally have some real clarity on what to do about it. So let's start with the big question we all face. You've done everything right. Their statin is maxed out, their blood pressure is perfect, they've stopped smoking. But that high-grade plaque is just sitting there. Does putting them through a procedure, whether it's a stent or surgery, actually add any real benefit on top of the best medical therapy we have today? And that brings us to this second critical question. Okay, let's say you do decide to intervene. What's the best tool for the job now, in this modern era? Is the classic surgical approach, endarterectomy, still the reigning champion? Or has the less invasive option, stenting, finally caught up?
Well, the answers to both of these questions come straight from the highly anticipated CREST 2 trials, which were published in the New England Journal of Medicine back in 2023. And of course, the links to the full bibliography are in the description below. Okay, let's dive into this.
First, let's just set the stage so we're all on the same page. We're talking about that patient at a true clinical crossroads. They have high-grade but completely asymptomatic carotid stenosis. This is something we find every single day in our clinics, and it's always been a tough call on what to do next.
And to be super specific, these are the exact patients who were enrolled in CREST 2. They had at least 70% blockage, but, and this is the key part, they had no warning signs, no stroke, no TIA related to that artery in the last 6 months. They are, by definition, clinically silent. So how did the researchers actually tackle this? You know, the real brilliance of CRS2 is in its elegant parallel design. It was perfectly built to answer our two key questions at the same time. So check this out. It wasn't just one trial, it was actually 2 trials running side by side. The first trial took patients and compared stenting plus intensive medical therapy against medical therapy all by itself. And in parallel, the second trial did the exact same thing, but with endarterectomy. This clean setup gave us a direct, head-to-head look at how each procedure stacks up against modern medical care. All right, so what did they find? Let's look at the stenting trial first. Did adding a stent on top of all those medications actually make a difference?
The answer was a pretty clear yes. Adding a stent to optimal medical therapy led to a 3.2 percentage point absolute reduction in the primary outcome, which was stroke or death, over a 4-year follow-up.
And this chart just says it all, doesn't it? The rate of stroke or death over 4 years plummeted from 6% in the medical therapy group all the way down to just 2.8% in the stenting group. With a p-value of 0.02, that result was statistically significant. That's a clear win for stenting. Okay, so a clear win for stenting, but what about surgery? What about carotid endarterectomy, the procedure that's been the gold standard for decades? I mean, surely it would show a similar benefit, right? Maybe even a greater one. Well, this is where the story takes a really surprising turn. While the number of events was a little lower in the surgery group, you can see it, 3.7% versus 5.3%, that difference just did not reach statistical significance. With a p-value of 0.24, we simply cannot say that adding surgery provided any proven benefit over medical therapy alone. And the authors themselves put it very plainly. They said that in the face of modern, intensive medical therapy, the added benefit of doing an endarterectomy for these asymptomatic patients just wasn't proven in their trial. And that, right there, challenges decades of established practice. So, what does this all mean for us, at the bedside on Monday morning? How do we take this really powerful data and translate it into what we do every day? Let's break down the key actionable takeaways. All right, here's your new evidence-based framework straight from CRS2. Number 1, the non-negotiable foundation for every single one of these patients is intensive medical management. That's our starting point. Number 2, if you do decide revascularization is needed, stenting now has solid level 1 evidence showing a significant benefit. And number 3, we now have to seriously question the routine use of endarterectomy in this specific population because its added benefit just couldn't be confirmed here. Look, if there is one thing to remember from all this, one little phrase you can share with a colleague to get the conversation started, it's this. With a silent artery, think CAS before CEA.
Think carotid artery stenting before carotid endarterectomy. It's a really simple way to sum up this practice-changing evidence. So, to wrap this whole landmark trial up, CRS2 powerfully reminds us that aggressive medical management is absolutely essential. It's the bedrock of everything. But on top of that foundation, it gives us a clear winner in carotid stenting for reducing stroke and death. And maybe most importantly, it casts some serious doubt on the added benefit of carotid endarterectomy for the asymptomatic patient in our modern era. So we'll leave you with this final thought. The evidence is in, and it really does challenge a long-held standard of care. The real question for all of us now is, how are you going to use this data to change your conversations with patients, your discussions with colleagues, and maybe even the protocols at your own institution? Disclaimer and bibliography in the description.